Hi everyone, my name is Soha. Did you know that Tehran University of Medical Sciences is the oldest and most well-known medical center in Iran, nationally and internationally?
Tehran University of Medical Sciences also has the largest school of dentistry in Iran. Take a look inside.
School of Dentistry is organizing its classes following health protocols. You will join large lecture classes like this.
Restorative Department of Dental School of Finance and Tissue Restorative Dentistry. Restorative dentistry is the main part of dentistry. Actually, it consists of two parts. Theoretical part and
For small practical classes like this.
I hope you picked the right major. Have you picked yours? This will come in a School of Dentistry. Go to TUMS website and pick yours.
During studying, we have access to a wonderful hospital, giving us opportunity to have more experience.
And of course, sometimes you need to relax. Dental konfliktiyeti esnaf bitiyoruz.
Hoş geldiniz. Bekliyoruz sizi.
We are waiting for you in a School of Dentistry TUMS.
Hello, my dear colleagues and audiences. Welcome to our third program on digital dentistry. On behalf of my colleagues from Tehran University of Medical Sciences School of Dentistry, I warmly welcome you to our program. On this program, we are going to talk about digital implant dentistry because everything has digitized in recent years, including implant dentistry. So we decided to talk more about this development. But as you know, implant treatment is a multi-disciplinary treatment, and we should have different because implant treatment includes multidisciplinary parts of dentistry. And so we have invited our colleagues from different departments inside Iran or abroad. Let's very briefly review our treatment. Implant treatments are based on implants placed inside the bone. So the quality and quantity of bone is very important for us. Also, the quality and quantity of the soft tissue, definitely. And the position, the diameter, the material, the form of the implants, the angulation. Then we have the prosthetic part that here again, the kind or the form of the superstructure, the material, and very detailed factors are important in our treatment. Now we want to see what to do with our treatment. If we want to make an analogy, implant treatment is like making a house over the pillars, and the number of the pillars, the distance between the pillars, the angulations, the how they are fixed to the ground are important according to, and they are designed according to our house or dream house that we have decided to build. And so when we want to start an implant supported treatment, and the first thing to know about our ground, that is the bone. We should know the quality and quantity of the bone. And the best tool for this is the radiograph. And nowadays we use CDCTs before treatment and also after treatment. And then the implants are placed. Then we take impressions and send it to the lab. And after that, we have some sessions between lab and prosthetic clinician, jaw recording, setting the tooth, designing the metal structures, and then making the denture and delivering it to the patient. The patient is the center of our concern. We want to make to do the best for the benefits of the patient. And if I don't talk about, don't mention the patient, I should emphasize that the patient is the center of our I'm sorry for interruption. We were talking about the conventional procedures in implant dentistry, implant treatments. Dr. Ghazanfari and Dr. That is a prosthodontist, and Dr. Russa, that is a periodontist, will talk about conventional versus digital implant dentistry. And Mr. Raymond Hakubian and Mr. Shahmiri will talk about the laboratory procedures digitally and conventionally. نمیتونم عوضش کنم. For digital implant dentistry, let's see what is new. As you know, we have new softwares that can help us in our treatment. It begins from the radiology softwares that Dr. Gudarzi and Dr. Bashizadeh will talk about it, and let's compare it with the let's talk about the conventional radiographic. We were using OPGs and because of course it is long ago, about 20 years ago, and we could just measure the buccal mesothelial because of the magnification of inherent in OPGs. The ball bearings were used to calibrate the OPG magnification and to find the correct measurement. This is a radiographic stent with ball bearings, and this side shows how the right side shows how the calibration was made on the radiograph. The buccolingual dimension was almost only possible to measure with the occlusal films, but because of the superimposition of the alveolar part over the basal part, finding the correct measurement was almost impossible. And just for the symphysis, it was possible to use symphalometry radiographs, but not for other parts. Nowadays, we have CDCTs. The first digitalization in implant dentistry was introduction of CDCT to in this area, and it helped a lot to find out the buccolingual, mesiodistal, occlusal, or alveolar basal dimension of the bone, and also the quality of the bone. So it was very helpful. And now we have design softwares added to our digital dentistry, and let's see what design softwares, how design softwares help us. As you see here, I'm not a professional surgeon at all, but when I see something like this, I will think that the best position is implant to be placed in this direction. But when this the prosthodontic design is made, we see that the vertical placement of implant is better, and I should say that and this design is confirmed by the surgeon. So this is how the implant planning softwares help us. Now, as I talked already, it is very important to have the software too, not only in soft tissue thickness and type 2, because in some situations, not knowing it may actually damage our work. You see here, this is our this is a conventional radiographic stand. This is CDCT taken and another scan. That's why I written here double scan. You see the very tiny line here. This line shows the mucosa, and it is very important for our designing in some situation like this. If you don't know how the thickness of the mucosa and the form of the gingiva, you cannot make your provisional restoration and during the implant placement or after that, or even design it prior to your work. So it is very important to have the form of soft tissue. You can acquire the data of the soft tissue by scanning and the cast of impression intraoral structure, or you can get the data from intraoral scanning, or you can have a scanning with the denture teeth of the patient's denture teeth. This is called dual scan technique. In dual scan technique, we scan the patient with its quite fit denture inside the mouth and CDCT scan, and then scan the dentures alone, and then merging them over each other. And some softwares can do this, and with this kind of scanning, with this technique, you don't need to make again the denture, and it is very helpful for tissue supported surgical guides, or even tissue supported treatments, implant placements, and designing your treatment. In the past, we have always in implant dentistry, even I had a glance over at a book from 1991, also integration and occlusal rehabilitation. They, in that book, was talking about surgical guides for implant placement. And but at that time, the implant placement was so simple, just with barium sulfate opaque, and most of the time you have the direction of implant placement just mesodistally and buccolingually. It wouldn't show the angle of the implant or the depth that implant should be placed. And as you see here, the angulation should be quite incorrect, and we have perforation of the cortical bone, and also the angle is, and also the depth could be very incorrect. Dr. Abbasi will talk about pilot guided surgery today, and then Dr. Mahsa Mohajeri will talk about implant surgical guides. Also, Dr. Farhis will talk about 3D printing in dentistry later on Monday. Now we are talking about surgical guides. We said that we should have a CDCT. We should have a scan of the mucosa from lab scanning, the CAS, or intraoral scanning or denture scanning. And then in the case of partially dentulous patient, we design the prosthesis and then make the surgical guide. These surgical guides helps you to put the implants in the places that you want most, and based on them, you can make provisional restorations or provisional bridges or anything that you want. But don't forget, for every work that you do, you should be professional in that part. Including how to use the softwares, how to use the radiographs, how to in the surgery or the prosthetic part of the treatment. Now let's jump after the placement of the implant, how we take impression. If we want to take inside the mouth and the implant position, we have to use scan bodies. And Dr. Mahia Hassanzadeh will talk about scan bodies tomorrow for us. Sometimes we have formed or for some reason the cavity area or mucosal area around the implant position inside the bone is larger than the scan body. We can individualize our scan bodies with the acrylic resin or composite and use it for scanning. Then this part of a scan body should be again be scanned outside with intraoral scanner, and all the data should be merged to each other. Now let's talk about a provisional restoration. If you have a provisional restoration and you have formed all the gingival tissues, the interproximal papilla, and everything is okay, and you want to have your CAD/CAM made crown exactly the same as your provisional restoration, if you just use the scan body, you may have the shrinkage of the mucosa and contracture of the mucosa, and you may lose the subgingival part that you have formed. So in these situations, you again can make a scan, intraoral scanning with scan body, and then a scan with the provisional restoration inside the mouth, and then scan the subgingival part of the provisional restoration outside the mouth, and then merge all of them on each other and together and superimpose them on each other and make a cast like this, a 3D printed cast like this, and do your work over it. CAD/CAM restorations also can be used in implant dentistry. As you see, this is a metal framework for Toronto Bridge. It can be, it could have been made with zirconia. All of them are made by the CAD/CAM technology. And as I said, Mr. Habibian and Dr. Shahmiri will talk about these techniques for us tomorrow and on Monday. Now let's go to the benefits of digital softwares for the surgery other than the surgical guides. As you know, I don't know much, but I have read that when your bone defect is very small, you just use GPR with resorbable meshes. But if you have more deficiencies like this, you use GPR with titanium meshes. Too much resorption of the bone. In too much resorption of the bone, you should use bone blocks for augmentation. Preformed titanium meshes have some drawbacks, like the risk of tearing the tissue and other things that our colleagues know better. And Dr. Jabbari will talk about it on Monday. We can design the customized or individualized titanium meshes It seems a very great step for the benefits of the patients, and we should remember that everything that helps our patients is a step forward in our treatment. But what I didn't see in or I didn't read at least is that if they design the prosthesis before designing the titanium mesh, because I think it is necessary to know where you want to have your prosthesis and to what extent and so on. So I should ask Dr. Jabari, although Dr. Jabari is a prosthodontist again also. And the other aspect that has helped a lot patients that cannot go on the has lost a lot of bone, have a thin bone, but they cannot go for augmentation with grafts like hip bones harvested from hip, or because some medical problems. In these patients also, there is a modality that in the past was used. It is a subperiosal implants, but because it needed two surgery, one for impression technique, taking from the bone and then making the subperiosal implant, and then there's a second surgery for placing it over the bone. It was abandoned, I should say. But nowadays, because of the CDCTs and the subperiosal implants can be formed over the CDCT, and then you may print it or you may cast it, but actually the surgery would be just one. About patient-specific implants, Dr. Gholamreza Shirani, that is a maxillofacial surgeon, and Dr. Mahnaz Arshad, that is a prosthodontist, will talk in details tomorrow. So what we do is to prevent complications, to give to restore the function and the speech, the comfort and the aesthetics for the patient, and to prevent complication. As I said, this is a kind of complication in my view. This is another kind of complication because the occlusion was not considered during the designing. In the software, we can know about the occlusal occlusion and if it has any impact on our design and our treatment planning. This is another complication, and I think it is not okay if we want to do some kind of treatment, although it is possible. Now, I'm coming to the end of my presentation. It is a question: who should know? Who should to be familiar with the different softwares and digital tools? I think all of us, both the radiologist, the prosthodontist, the lab technician, the maxillofacial surgeon should know about the capabilities and also deficiencies of the softwares. Some of us should know in our profession more about these capabilities, some less, but all of us should be familiar with them. Thank you so much for your attention. I hope you enjoy our program and it helps you to know about it.
Choosing some majors, you will have to pass long academic years and spend much money. Wait, TUMS has a great offer for you. Do you know by studying dentistry and pharmacy, you will save time and money, study less difficult and complicated courses, and above all, you will have a great job opportunity? This is the last time our DDS and PharmD programs are on a special offer with 50% reduction. DDS from $7,500 to $3,500. DDS from $7,500 to $3,750. B-Pharm, M-Pharm, and PharmD from $6,500 to $3,000. It's time to take action. Don't hesitate to use the new chance.
All right, good morning, everybody, colleagues, students, and dear faculties. This is the third course that we are presenting in Tehran University School of Dentistry. And we are moving on with the next lecturer, Dr. Ghazanfari. She graduated from Tehran University in 2016. And since there, she's practicing in the private practice. And also she's a faculty member of Tehran University. Her topic is digital versus conventional implant dentistry, prosthetic point of view. Dr. Rezvaneh, please move on with the next topic. Thank you. All right. For the audience, if there is any question comes up in the middle of the lecture, you can write it down and message it for us so we can discuss in the end of the topic, end of the lecture, or during the break time. Dr. Rezvaneh, if you're on, please move on.
Thank you, Dr. Sadaqpour. Good morning, everyone. This is Rezvaneh Ghazanfari, and in this presentation, I will compare digital workflow and conventional workflow in implant dentistry from prosthetic point of view. As you know, one of the most important factors in order to achieve a successful treatment outcome is restoration-driven implant placement. Actually, in this part, which is the first part of this presentation, I will focus on conventional workflow. In conventional workflow, in order to follow the concept of restoration-driven implant placement, we have to make a conventional impression. After that, we fabricate a dental model, we do a setup, and after the next step is 2D image with radiographic splint, and the next step, which is very important in treatment planning, is preoperative planning, and according to this planning, production of drill guide will be done. By the use of this drill guide, which helps the clinician to ideally place the implant, implant surgery will be done. And that would be the end of surgical state of conventional workflow in implant dentistry. The next stage, which is prosthetic stage, in conventional workflow of implant dentistry, starts by making an analog impression. After that, working casts are fabricated according to the lots of factors, actually, based on the working cast. clinician order the abutment, and on that abutment, final restoration will be fabricated, and the trying and delivery appointments will be done. Lots of different techniques may be used in conventional workflow of implant dentistry. We can categorize impression technique mainly into two groups. One of them is abutment level, and the other one is fixture level. In order to make it possible, the comparison of conventional and digital implant dentistry, in this context, we focus only on fixture level impression technique. In conventional workflow, fixture level impression technique is categorized, and it's divided into two groups. One of them is open tray and the other one is closed tray. In this photo, open tray technique is clearly illustrated. As you know, after removal of the healing abutments, the impression coping is seated on the fixture and it is hand tightened. In this technique, we use an open tray with a hole in specific and exactly on the impression coping. And after that, we load the material, and after the removal of the impression from patient's mouth, we have to sit the analog components on the impression and hand tighten it. The other technique that is used in order to make an impression in conventional implant dentistry is closed tray technique. In closed tray, we use a tray without any hole, and as you can see, the shape and the form of the impression coping is totally different from the ones that's used in open tray technique. After the removal of the impression from patient's mouth, we have to remove the impression coping from the patient's mouth. We have to connect it to the analog, and we have to seat it on the impression. Conventional methods of making an impression in implant dentistry, however, has got lots of different disadvantages. One of the most important disadvantages of this technique is dimensional changes of our impression. The other one is the fact that this technique requires a great amount of working time. It requires patient compliance, and we have to do some more laboratory and clinical steps for this technique. In the next step, the impression is used to fabricate working casts on which soft tissue is also duplicated. And you can see the picture of this working cast in this slide clearly. Then, in the next step, according to the occlusal, interocclusal space, and lots of other factors, the clinician decide to choose between cemented restorations and screw retain restoration. And according to the type of the restoration, according to the angulation of the implant, depth of the implant, and lots of other factors, the clinician order abutments. As you know, implant abutments are basically categorized into two groups. One of them is prefabricated implant abutments, and the other one is custom-made implant abutments. In conventional workflow of implant dentistry, predominantly custom-made implant abutments are chosen and ordered. In the next step, the restoration will be fabricated. The most common type of restoration which is indicated in conventional workflow of implant dentistry is porcelain fused metal, or metal ceramic restoration, in which metal framework is fabricated by conventional casting technique, as is clearly illustrated in this slide. And after that, porcelain will be added to this restoration in order to complete the contour of the crown. Then this restoration is transferred to the clinic, and it will be tried in the patient's mouth, and finally it would be delivered to the patients. And that is the end of the conventional workflow of implant dentistry. In the next part of this presentation, I will discuss about digital workflow of implant dentistry. Actually, this workflow is known to be more accurate and more predictable, and the treatment outcome would be better. And of course, one of the most important advantages of this workflow is elimination of the number of steps. By the utilization of different digital tools and modalities such as CDCT, intraoral scanners, extraoral scanners, CAD/CAM technology, rapid prototyping, and 3D printing, it would be facilitated to follow digital workflow in implant dentistry. In this part, I will focus on different types of different methods of digital manufacturing. Digital manufacturing can be is categorized into two main groups. One of them is subtracting manufacturing technology, SMT, and the other one is additive manufacturing technology, AMT. In these two photos, you can clearly compare two methods, subtracting and additive. On the right photo, you can see that in subtracting technology, the object in this context, the restoration is milled out of a blank or block, and in additive technology, the object is manufactured by adding layer by layer of the material in order to shape the final object. Exactly the same as conventional workflow. In digital workflow, restoration-driven implant placement is the main concept and is the main focus of the workflow. However, in this workflow, digital workflow, computer-assisted implant surgery, or CAIS, offers additional helps to the clinician in order to make an accurate treatment planning, do better surgical placement, and finally, prosthetic rehabilitation will be more efficient and easier. In this approach, the interdisciplinary approach should be followed. In the surgical stage of digital workflow of implant dentistry, we have to focus on virtual implants planning by the use of 3D imaging. In the first step, intraoral scan and imaging, CDCT, will be used. And after that, we have virtual setup. And in the next step, we have preoperative planning. And after that, printing of the drill guide and finalizing the implant surgery. Therefore, in order to in order to start our workflow digitally, we have to make a CDCT scan. After that, we have virtual preoperative treatment planning. In the next step, the data are transferred to dental laboratory in order to manufacture the surgical guide, and finally, the implant surgery. Therefore, we can say that we have 4 main steps in surgical stage of digital workflow of implant dentistry. The first stage is data acquisition. Data related to bone as acquired by CDCT and data related to mucosal surface and remaining teeth as acquired by virtual dental model. The next part is data import and pre-processing, which is done by virtual dental model and utilization of CDCT data. And the third part, which is CAD, computer assisted design. In this step, virtual prosthetic setup, virtual implant placement, and drill guide design is performed. And in the fourth step, which is CAM or computer assisted manufacturing, the drill guide will be produced in the office or in the laboratory by milling or 3D printing technique. Therefore, in a fully digital workflow or process, I have to say that the prosthetic setup is constructed virtually, and designing of the implant guide template is performed on a screen. And based on these 2 facts, the number of operational steps is reduced significantly. Now, here is an example of a surgical stage of digital workflow of implant dentistry, which begins with the intraoral scanning of the edentulous area. After that, the final restoration, the future restoration, will be designed in order to provide best tissue and best tissue support, and based on the design of future restoration, the ideal position of the implants will be defined and designed. According to the ideal and selected implant position, a drill guide will be fabricated digitally by the milling or 3D printing technique, and in surgery appointment, surgical appointment, the surgeon will use it in order to place the implant in its accurate position, as it's illustrated clearly in these slides. That is the end of surgical stage of digital workflow of implant dentistry. Let's review it. We made a CDCT scan. We made an optical scan. After that, treatment planning, virtual placement, surgical guide scan, surgical guide print, and finally dental implant placement. In the next stage, which is prosthetic stage of digital workflow of implant dentistry, scan body, CAD/CAM customized abutments, CAD/CAM abutments, milling systems, and fully digital workflow will be used in order to produce the final prosthesis. Now let's focus on digital impression. Before using digital impression and before talking about digital impression, we have to make a reasonable justification for utilization of digital impression. As you know, one of the most important justification of this technique is the fact that it is easier, it is better, and it is more efficient. It provides more patient satisfaction and compliance, and it's make it possible to remake our impression very quickly in a short period of time. It's reduce and it's eliminate the possibility of dimensional changes, shrinkage. In order to make a digital impression, digital acquisition units are required. Digital acquisition units are basically divided into two groups. First group is sole impression system, and a second group is CAD/CAM impression systems. Sole impression systems only make impressions, only can make digital impressions. On the other hand, CAD/CAM impression systems make digital impression and provide CAD/CAM technology in which computer-assisted design and computer-assisted manufacturing will be performed. Here is an example of making a final restoration by the use of digital technologies. In the first step, we have to use scan body, and we have to make an intraoral scan. Based on data acquired from this scan, final restoration will be milled and will be cemented in the patient's mouth. So, in complete digital workflow, by the focus on prosthetic stage, we have to make an intraoral scan with a scan body. According to the data acquired, we order the abutments, we design, mill, or finalize the crown, and finally we deliver it to the patients. Here, you can compare intraoral scanning with conventional impression, conventional methods of impression making. You can see that in order to make an intraoral scanning, we need a scan body, which is equivalent to the impression coping. This scan body is unique to each implant platform, and it is used in the same way as impression coping. It is hand tightened in the patient's mouth on the fixture, and in order to verify its accurate seating, we can take a radiograph, and after that, we make the digital impression. Data acquired by this technique is transferred to the laboratory, and we can use data in order to print a model. Exactly the same as conventional workflow. In digital workflow, in the next step, we have to do abutment selection. Most of the time, customized abutments, which is fabricated by subtractive milling technique, is selected in digital workflow. And based and on this abutment, restoration will be fabricated. And that would be the end of prosthetic stage of digital workflow, you can see that the number of steps would significantly reduced. In conclusion, digital workflow provide precise and predictable treatment outcome, and in this technique, we can individualize our treatment for each patient. In this technique, there is no need for any physical models. However, digital workflow and starting this workflow requires steep and gradual learning curve. I mean, the clinician has to be familiar with associated complication of this workflow. In this presentation, I mainly focus on conventional or analog workflow and complete digital workflow. However, in between these two workflows, there is another workflow which is called partial digital workflow. In this workflow, the combination of different steps of digital and conventional workflow may be utilized. For example, you can make the impression conventionally and after that send it to the laboratory in order to fabricate working casts, and ordering the abutments would be done, and in the step of restoration production, milling technique, which is a digital technology, will be used in order to produce the final restoration, and the crown will be tried in and delivered to the patients. Here you can see the example of the combination of digital and conventional workflow, which is partial digital workflow. And by combining different techniques of these two workflow, we can use a great variety of materials, techniques, systems. As you can see, we can fabricate a framework by different techniques, and the clinician is the one who has to decide to choose between these three modalities. I mean, digital workflow, conventional workflow, or the combination of them. That is the end of my presentation, and thanks for your attention. If you have any question, don't hesitate to ask.
All right. We are done with the first lecture. Dr. Ghazanfari, thank you so much for the nice lecture. For the audience that they joined us recently, I would like to represent the course, which is a 3-day course. Started today morning, and now we are moving on for the next session, which is regarding surgery. Our next lecturer is Dr. Rusta. She's a periodontist. She's a faculty member of Tehran University since 2008, and she also got the fellowship in implant dentistry, and her topic is regarding digital versus conventional implant dentistry, periodontics point of view. Now let's see if she's in the speaking room so we can connect her and ask her to move on. For the audience, there is a chat room here. If you have any question coming up regarding the last lecture, you can write it down here. So while the lecturer is here, we can discuss about that matter. she there? All right, that's fine. Don't worry. من قطع شد.
We are all familiar with conventional prosthodontics, how to prepare teeth, how to make impressions, the laboratory procedures and delivery steps. But like other aspects of our lives, prosthodontics is getting more and more digitalized. And being familiar with digital prosthodontics, especially CAD/CAM technology, is mandatory for an up-to-date dentist. That's why we have planned a short course in digital prosthodontics. Join our outstanding program at Tehran University of Medical Sciences, School of Dentistry.
Hello, my dear colleagues, my dear friends. It's my honor to be here in the short course directed by my dear colleagues, Dr. Farid and Dr. Sadiqpour from Prosthodontics department. I'm Dr. Rusta from Department of Periodontics. We will have a 30-minute about, I don't have my, we are going to have a 30 minutes on the computer-assisted implant surgery. First, as an overview, in this 30 minutes, we are going to have has a review on the clinical outcome of computer-assisted implant surgery, its benefits, advantages, and disadvantages compared to the freehand implant placement. As you know, with the promotion of computer-assisted implant dentistry, we only have a surgical guide at the time of the surgery, and it helps us to do a step-by-step drilling procedure and then place the implant through the guide. And we are going to the automation. You know, there are two types of guided surgery. With dynamic guided surgery, the surgeon has a real-time navigation system. Directly, the surgeon can see the surgical field through a monitor. But with static guides that today we are dealing with it, the static guide is the most commonly used method. And with static guide, there is no option to change the surgical procedure during the surgery. But with dynamic guided surgery, the surgeon has the option to modify, to change the surgical procedure according to the anatomical finding. Is there any advantages for the clinical computer-guided implant surgery? Of course, yes, and of course, there are some disadvantages. We know that with computer-assisted implant surgery, we have the opportunity to first determine the accurate position of implant in 3D structure. and then place the implant according to the 3D planning in accurate position. When the implant is placed accurately, so the anatomic structures will be protected from surgical injury, and it leads to the less surgical time. In addition, we have the chance to perform our procedure according to flapless approach, but it needs some restricted criteria to do flapless surgery. Therefore, we need less for bone augmentation, and patient will have greater satisfaction. Okay, as I said, the major benefit of computer-assisted implant surgery is the ability to plan the accurate 3D position of the implant. Let's have a brief view on the literature about the accuracy of computer-assisted implant surgery. Several studies have evaluated the deviation of the implant placed with computer-assisted techniques. This deviation has been evaluated in the entry point as the linear distance, in the apex point, again, as the linear distance, and the angular deviation of the implants. Fortunately, different studies for single implant placed according to computer-assisted surgery has reported minor deviation from the ideal position. The mean deviation reported at the entry point was about 1 millimeter, at the apex was 1.2 millimeter, and the angular deviation was reported to be 3.8 millimeter. These are mean values. And the mean vertical deviation for single implants has reported to be about 0.5 millimeter. But there are reports on greater amount of deviations. The greater deviations has been reported for partially edentulous patients, especially when the implant are placed in the edentulous maxilla. For the fully edentulous maxilla, you can see here up to 8 millimeter deviation at the entry point and up to 9 millimeter at the apical point has been reported. And these are very significant amount of variation from ideal position. این میتونه جابجا بشه دقیقاً روی تایتل من. Which factors could influence the inaccuracy of the implant placed according to computer assisted? Every single step, from patient evaluation to taking CDCT, to planning, and then executing the procedure could influence the accuracy of implant position. Some errors in CDCT, for example, greater slice thickness resulting more inaccuracy, movement of the patient, metallic restoration defect, errors in intraoral scanners. But some anatomical factors like thickness of the mucosa. The greater the mucosa, the greater the amount of inaccuracy of implant position. And it is very important to know that the type of guide support could influence the inaccuracy. There are several different type of support for the surgical guide. The guide could be supported by tooth. In both ends of the guide, these are tooth supported surgical guides. They could be supported by mucosa, and they could be supported by bone. And there is another type of support, special supported guides. It means that before the planning procedure, we could place some mini implants in the edentulous ridge, and then planning is performed according to this special type of support for the guide. And the best type of guide is too supported by guide because there is the minimum amount of movement and it leads to the least inaccuracy of implant placement. For fully edentulous patients that we use mucosa supported or bone supported, the guides must be fixated via fixation pins. If the guides are not fixated, then we will have a great amount of inaccuracy. So in order to improve the accuracy, it is better to reduce the number of steps from patient examination to execution of the surgery. And it is better to use a stiff supporting system. To support it is better than mucosa supported or bone supported. And for mucosa or bone supported, we have to use fixation pins. Fully guided systems are better than partially guided or only pilot drill guides. And it is very important to know that the clinician must have basic and comprehensive knowledge and skills about the conventional implant dentistry, because every single step of computer-assisted implant surgery must be confirmed by the clinician. And the other point is that for the fully edentulous patient, the best option for the minimum inaccuracy is to use fully guided placement with fixation screw and use flapless approach in order to minimize the movement of surgical guides. Now we are going to have a look at the clinical outcomes of computer-guided surgery. For the single-tooth implant placed with computer-assisted surgery techniques, the amount of angular deviation has been reported to 2.6 degrees, while for freehand deviation, I mean, without the use of surgical guide, the deviation from ideal position has been reported to be 7 degrees. Again, for deviation in implant shoulder position and implant apex position, there are greater amount of inaccuracies for freehand techniques. But there is a point here. For computer-assisted implant surgery, studies have reported less amount of insertion torque. We have less insertion torque, mean value 22 Newton centimeters compared to insertion torque of 35 Newton centimeters for freehand deviation. There is a technical problem with computer-assisted implant surgery because we are drilling and we are inserting the implant through the cylinder in the surgical guide. And we don't have any direct vision and direct sense of the bone density. So when we are using computer-assisted implant surgery, there is a risk for having less insertion torque. We are going to have a look at some criteria for clinical outcome of implant surgery. Survival rate for computer-assisted implants have reported to be 96 to about 100%. That is similar to freehand approaches. So there is no difference between computer-assisted surgeries and freehand surgeries regarding cumulative survival rate. The other parameter is crestal bone loss, and you know that we expect the crestal bone loss after bone remodeling be less than 0.02 millimeters per year. About computer-assisted implant surgery, Dr. Nixat has reported after 1 year of implant placement, crestal bone loss was about 0.6 millimeters. And again, for single implant placed with computer-assisted techniques, mean marginal bone loss after 12 months was reported to be 0.3 millimeters, and after 3 years, it was 0.5 millimeter. That these values are in the field of optimum values for us. The other parameter is aesthetic outcome. Verhauser evaluated single implants in the aesthetic zone and followed them for 2.3 years. They reported low 3D inaccuracies. As I said before, 0.8 millimeter at the implant shoulder. But note that the most frequent deviation reported was in buccal direction. And you know that the deviation in buccal direction could result in problems in aesthetic and as well as biologic problems. Fortunately, in this study, pink aesthetic score was reported to be 13 for implants that were in accurate position and were reported to be 9.5, significantly less than ideal scores for buccally deviated implants. Another study evaluated 24 single implants in the anterior maxilla with 15 months follow-up. They compared biological parameters between flap-reflected techniques and flapless techniques. Please note that for keratinized gingival widths, when the flaps were reflected, there were greater amount of keratinized gingiva compared to flapless techniques at the baseline measures. But when the time goes on, after 15 months, fortunately, the difference between flapless and flap-reflected techniques goes to be the minimum without any significant difference between two groups. So pay attention that when we are using flapless techniques, especially with guides, there might be a risk to have less amount of keratinized gingiva. So we should be careful about the amount of keratinized gingiva with flapless techniques. Fortunately, difference in papilla index between these two groups, flap-reflected and flapless techniques, was not significant. Another study compared freehand implants and digitally placed implants. Fortunately, there were no difference regarding gingival index, papilla index, and other biologic index, although there were better results in digitally placed implant compared to freehand implants. But these differences were not statistically significant. Regarding the cost effectiveness of computer-guided implant versus conventional implant, there is a study comparing hybrid prostheses in long-term follow-up for 5 years. They followed 149 implants placed with computer-guided compared to 111 non-computer-guided implants. They reported the implant survival to be significantly more for computer-guided implant compared with non-guided implant. And the prevalence of periimplantitis was higher in non-computer-guided implant compared to computer-guided implant. And we can say that it is due to the accurate position of the implant in computer-guided techniques. But there were no prosthetic complications between computer-assisted implant and freehand implants. But when we go to the cost analysis, there was a significant increase in initial costs in computer-guided implants, about $700 for every patient compared to non-computer guided implant. But when the times lapse, the mean total cost will be similar between groups, and this is due to the complications occurring in the non-computer guided implants. So in the long term, there is no difference in cost analysis between these two groups, but in short term, computer guided implants has significantly more cost compared to non-guided implants. For full mouth rehabilitation in edentulous maxilla, there is a systematic review. The implant survival after 5 years has been reported to almost 100% in non-smokers and 81% for smokers. That in these values are similar to freehand implants, as you know. And marginal bone loss after 5 years was reported to be 1 millimeter for non-smokers and 2.6 millimeters for smokers. And these are again in optimum value and similar to freehand implants. With computer-assisted implant surgery, we have the opportunity to do flapless surgery. And you know, there is so many advantages, especially for the patient. Lower pain, postoperative pain, lower morbidity, high patient satisfaction, reduction in chair time, by stress reduction for patient. But for flapless implant surgery, there is a risk of bone perforation. So we have to do flapless surgery only when we are doing computer-assisted implant surgery. And with flapless surgery, we cannot do bone augmentation or soft tissue augmentation. And these augmentations are limited to tunnel approach, and these are very technique sensitive. So when we want to do flapless surgery, we should consider the amount of keratinized gingiva and the amount of available bone. And we only are allowed to do flapless surgery when we have adequate amount of keratinized gingiva and adequate amount of bone around the implant. There are some limitations for aesthetic computer-assisted implant surgery. We have limitation, we have inability to change or modify our surgical technique when we are using guide, a static guide. And the only choice for a change in the surgical process is to change the approach to freehand approach. And we should again remember that the clinician must be a comprehensive skill and knowledge of implant dentistry. And any error in planning and drilling system will lead to a wrong implant position and will lead to a disaster for the patient. Here we have a case treated with computer-assisted surgery. He is a patient, partially edentulous in 3 segments of posterior jaw. As you see, we planned prosthetic for the patient according to crown down approach. The implants were planned in 3D accurate position. The second premolar is type 1 or fresh socket implant placement, and first premolar is type 4 or delayed implant placement. This is fully guided implant placement. It means that in addition to the drilling, the implant placement is also done through the surgical guide, and it could minimize the inaccuracy of implant placement. Okay, we have don't enough time. So this is the immediate post-operative view of the patient. We performed the surgery according to flapless concept. You can see here there is adequate amount of keratinized gingiva in buccal side, and there is no change in mucogingival position. And this is long-term follow-up of the patient after 2 years. You can see here everything is stable. Crestal bone has remodeled in the optimum position. And this is again 2 years follow-up of the patient. This is after 2 years. You can see here the remodeling of the alveolar process is being continued. So the implant placement is not, it could not prevent remodeling of the alveolar bone. This is another case. I want to show you some drawbacks of computer-assisted implant surgery. For this patient, a mucus-supported guide was used, fixated with anchor pins. The implants were placed according to flapless technique. And you can see here, in the premolar region, there is insufficient amount of keratinized gingiva. There is another drawback of computer-assisted implant surgery when we use fully guided implant. Here, because we cannot see directly the bone and the anatomy of bone, especially when are doing flapless surgery, you can see here one of the implants were positioned too deep, and it could result in deep pocket after loading. So when we find this problem, we corrected it with a mini flap for the patient. So the implant position was corrected for the patient. And after osseointegration time, we wanted to do second stage surgery. Again, we placed the guide for the patient and we punched the soft tissue. Here you can see there is ideal amount of keratinized gingiva except in these two implants, premolar region, in both sides. So in order to augment the amount of keratinized gingiva, we used a pedicle palatal flap. We rotated the flap to the buccal side and corrected the lack of keratinized gingiva. And this is 6-month follow-up of the patient. So you could see that computer-assisted surgery could have some drawbacks, especially in the alteration of technical procedure, and especially when we do flapless surgery, it could result in insufficient amount of keratinized gingiva around implant. As a concluding remark, I want to remember that the accuracy, efficacy, and complication rate of computer-assisted implant surgery is in the is similar to the freehand implant position, but the main benefit of computer-assisted surgery is the accuracy of implant placement in optimum 3D position. And proper execution of each digital workflow must be carefully verified to reduce inaccuracy. I want to thank you, my dear colleagues, to participate in this short course, and especially I want to be grateful to my colleagues, Dr. Farid and Dr. Sadiqpour, for letting me to be here at your service. Thank you so much.
Thank you so much for your very nice and comprehensive presentation, Dr. Rustab, and we are so honored for your presence in our program. Thank you so much.
So we have
my pleasure, Dr. Farid.
Okay, there is a couple of questions regarding surgery. Would you please, Dr. Sadiqpour?
Yeah, there's a couple of questions regarding the surgery. The colleague is asking regarding the length of the surgical drills. any difference when you are placing an implant with the surgical guide as far as the length of the drills, or is there any specific surgical kit for this type of surgery?
Every system has a special kit for computer-guided implant placement. And as you said, the drill links must be longer than standard drills, because the amount of difference between the guide and between the mucosa must be added to the drill length. So the drills are longer, and we are not allowed to use the conventional kit for computer-assisted implant surgeries. There must be the special kit.
Perfect. And there is another question regarding the provisional phase, which the colleague asking which type of provisional restoration you recommend for this phase. We do have Dr. Farid here. So now we are done with the surgical part with Dr. Rusta. We are very honored to have you here, and thanks for the wonderful lecture. Hopefully see you next year.
Thank you so much, Dr. Sadegpour.
All right, for the next question, Dr. Farid, there is a question regarding provisional phase.
Is the possibility to take digital impression with the scan body at the session of the surgery? Yes, if you have done the surgery flapless, if you have made a large flap or something that has damaged mucosa, not saying damaged, as your mucosa is not very good for scanning, because when you want to use a scan body, you should be able to scan it. And with the blood and many other factors that may affect the scanning, it may be not possible to scan perfectly. So just you can use a scan body at the session of surgery if your mucosa is not much lacerated, and somehow it's better to say that you can use it when you have flapless surgery. And is it a screw type provisional or like Maryland bridge? We use Maryland bridges when we don't put the provisional on the implant. So when you have implant supported restoration, there's no need for Maryland bridges. If there's another question, please write it, and I hope I have answered you correctly. And
so for the single unit missing area, if there isn't any crown restoration on the adjacent teeth, so we are able to use Maryland bridge or any type of resin bonded restoration. But if there is some type of restorations on the adjacent teeth, so we do have option to make a provisional restoration on the implant. So it's your preference. Myself, actually, I do hesitate to do immediate loading for the risky patients or for the posterior area. But for the front teeth, sometimes we don't have any choice, and we go for the immediate loading with the implant supported screw retained restoration. But for fully edentulous patients, since we do have a type of cross stabilization, so we have more confidence to make a long span provisional restoration for the patients, and it's very predictable. And that would be the best option for fully edentulous patients. Depends on the number of the implants. If you have the minimum number of implants, it's a very successful treatment. So as I see here, there is no other question. We have like a half an hour break here. So See you in half an hour. Thank you so much. Are we done? Let's go ahead. یا آمدین اینجا ready? All right, dear colleagues, we are moving on to the next session. As you see here, we are moving toward the radiology topic. The first lecturer is Dr. Gudarzipur. He is radiologist since 20 years ago and a faculty member of Tehran University School of Dentistry. His topic is new concept in radiographic assessment of dental implants. So, Dr. Gudarzipur, welcome, and please carry on.
Dr. Gudarzipur, the screen is yours. We can't hear you. Are you talking?
Hi, everyone. Thank you, Dr. Sadehpour, for introducing me. Hi, everyone. First of all, let me thank coming here today and share your time with us. As you will see, the subject of my presentation is radiographic assessment of dental implants. Now, it is better to share my slides. Do you see my slide, Dr. Sadehpour?
Yes.
Okay.
No, but we can't see your slides. Have you shared it? Have you shared your slide?
Yes, I've shared.
No, we can't see it. No, we can't see it.
Okay. Give me 5 seconds. I will share it for you.
Sure. Yeah, it's coming up.
Okay, thank you. If there is any question, please write your question down in the chat box. I will ask all of your questions in a proper time. As you know, clinicians have to get complete information about the jaw bones to planning a successful treatment for implant. Also, during the surgery or during the prosthetic procedure, a dentist may need to prescribe some imaging modality to get some information for solving the complication or to continue the treatment. In follow-up phase also, a dentist may need to prescribe a radiographic technique to trace the success of the treatment or to see the problem or complication. And then it is mandatory for dentists to know a complete information about imaging methods as a tools for planning a treatment or to treat the patient using implantology. We use a radiographic image to see all information about the bone quantity, including height, width, and morphology of the jaw bones. As you know, all of these parameters affect the treatment of the dentist, and it is better that dentists know about these items three-dimensionally. Also, bone quality is another matter that dentists should have information about it. Unfortunately, many of the imaging techniques suffer severe limitation to show bone quality. Bone quality provide comprehensive information for the dentist to know about the implant site and to decide which treatment is better for the patient. Which radiographs is proper for us, or characteristic of a proper radiography make the dentist available, capable to plan a successful treatment. We need a radiograph to evaluate the alveolar ridge and adjacent structure in all 3 dimensions. As we insert the implant in a jawbones which has 3 dimensions, the dentist should know the information about all 3 dimensions of the jawbones. Then a good radiograph and a proper radiograph should have capability to provide the information about all 3 dimensions. A proper radiograph can lead the dentist to choose the site of the implantation, the number of the implantation, or to choose and select the size of the implant. And also during surgery, the dentist and clinician can choose the orientation for implant insertion. The dentist can evaluate the anatomic structure that may interfere with the treatment, like incisive foramen, mental foramen, inferior alveolar canal, existing teeth, nasal fossa, and maxillary sinus. Then evaluation all of the anatomic structures. Adjacent to the implant size should be done by dentists using radiographic methods. Also, some conditions like retained roots, impacted teeth, or osseous pathology may affect directly the planning of the dentist. Then the importance of choosing the best radiography is completely obvious. What is the characteristic of an ideal technique? Among various radiographic techniques which is available for a dentist, which one of them is the best for his or her patient? As you can guess, ability to visualize the implant size in all 3 dimensions is one of the most important characteristic of a radiographic imaging technique. The dentist should observe mesiodistally, faciolingually, and inferiorly the jaw bones to decide the correct implant treatment. Also, the dentist need to measure something on the pictures to planning a treatment or to selecting the fixture or implants. Then the technique of choice should be able to provide accurate and reliable measurements. Accuracy and reliability are both important parameters that may affect the implant treatment. It is better that our technique of choice correlate imaging site and clinical site together. And also, like any other radiographic techniques, the imaging modality should be available for the patients, and cost of the imaging modality is important also for the clinician and patients. Like any other radiographic prescription, we have to follow as low as reasonably achievable or ALARA rule to avoid unnecessary exposure to the patient. We have to use a technique with minimal radiation dose if we can. There is a flow chart that has been written in many textbooks for prescribing the radiographic techniques in implant dentistry. Assume that one patient come to a dental office to get service for implant treatment. After clinical observation, if the dentist or clinician conclude that the patient is a good candidate for implant, or the clinician has doubt about it, she or he can prescribe a second level of X-ray imaging techniques, including conventional radiography such as panoramic or periapical. After observation or examination of the radiography, first level of radiography, if still the patient is a good candidate for implant, or still there is any doubt about it, the clinician can prescribe the second level of X-ray technique like CDCT, and it is important in each level the negative patient that are not a good candidate for implant, it is better not to order any radiograph for them. And only we have to prescribe the radiography for positive or doubtful patients. As I mentioned before, there is so many imaging modalities, and the expert clinician should choose the best technique for each patient. We start from intraoral radiography. One of the most advantages of intraoral radiography is its high resolution and proper sharpness of the image. But unfortunately, intraoral radiographs like periapical and biting suffers from insufficient coverage because the sensors and fields of intraoral radiographs are not sufficient for cover broad anatomic structures. Also, periapical and bite wings have foreshortening and elongation that may lead to inaccurate measurements. Then it is important for us that we know measuring using the intraoral radiographs is not correct and may lead to malpractice. One of the most important limitation of intraoral radiography is that no cross-sectional image can be showed on this picture. Only 2 dimensions can be seen in intraoral radiography. It is better to use periapical and bite wing to evaluate the adjoining teeth, or if we want to check the fitness of the cupping, or if we want to follow up the inserted implant to see the possible peri-implantitis, or if we want to check the extent of osseointegration, it is better to use intraoral radiography, especially periapical image. And Also, we can use periapical radiographs to evaluate architecture and quality of bone preliminary. But these techniques suffer from showing precise and exact quality of the bone, and the exact quality only can be available on advanced technique. One of the other and well-known radiographic techniques is panoramic radiography. As you know, its advantages and limitations. As you can see on this image, the most important advantage of a panoramic radiography is very broad coverage of anatomic structure. For a patient that needs to implant treatment, it is essential to see maxillary sinus, nasal floor, inferior alveolar canal, or remaining teeth to plan a good implant treatment for the patient. And panoramic radiography can provide such information for the dentist. But unfortunately, resolution and sharpness of panoramic radiography is less than even intraoral films. And still, distortion and inaccurate measurement is one of the other limitations of the panoramic radiography. Then we can use panoramic only for initial evaluation of alveolar bone and cortical boundary of the anatomic structures, like mandibular canal, maxillary sinus, and nasal fossa. As I told before, panoramic radiography and periapical radiography can be considered as first level of X-ray imaging that can be used in implant treatment. But after radiographic examination of these techniques, we can continue to second level or advanced techniques. I mentioned something about cross-sectional or third dimension of the jawbones. In this slide, you can see the importance of observe the third dimension of the jawbones. In the right pictures, at the above and below, it seems that the implants is inserted correctly without any problem. But at the left pictures, you can see the extent of the problem. Both pictures perforated the buccal and lingual cortices, and both of them has severe problem. Then two-dimensional radiography is not sufficient to observe the jaw bones for implant and to insert the implant correctly. Home beam computed tomography has been emerged to dentistry in recent decades and is widely used by dentists. It is essential for dentists to know the exact characteristics, advantages, and limitations of this technique to use this imaging modality perfect. One of the advantages of cone beam CT is low patient dose. Of course, considering other cross-sectional modality and not conventional modality. The cone beam CT comparing to conventional radiography has more patient dose. But considering the information that using CDCT can provide us, the patient dose can be safely used, and we have to know that the patient dose of cone beam CT is lower than other cross-sectional imaging modality like medical CT scan. Also, using cone beam CT, accurate measurements can be available, and we can measure anything on CDCT images accurately and reliably. The resolution of cone beam CT is favorable, and we can see details of jaw bones by this technique. Procedure of cone beam CT is comfortable for the patient, and after taking the image, there is an interactive software that can be transferred to the dentist, and dentist can examine the image by scrolling the plans one by one, or the dentist can measure anything which they want again. Then this facility is very important for both radiologists and clinicians. In CBCT techniques, we can capture a volume of the jaw bones in one exposure. You can assume a cylinder-like of the jaw bones, which can be captured using cone beam CT. After that, all the data of this volume could be used for reconstruct any multiplanar image considering the diagnostic requirement. If you want to reconstruct or extract an axial plan, something like this, you can extract it from the whole volume which has been captured. Or if you want to reconstruct a sagittal plane, also it is available. Even you can reconstruct a curvilinear plan like panoramic, and you can see this plane for clinical requirements. One of the frequently asked questions is how much dose the CBCT does have. As you can compare the exposure dose of cone beam CT comparing panoramic, it will lead about 4 times exposure dose comparing to panoramic. But still, it is 10 times less than other cross-sectional images like medical CT. Then, if we want, and if we have to get a cross-sectional image, the best technique of choice is cone beam computed tomography. This table is a comparison between effective dose of CBCT with other medical imaging techniques. You can compare the equivalent natural background radiation of cone beam CT comparing to some other techniques like barium enema, or a cardiac study, scintigraphy of the heart, or a medical CT of the lung. And you can see that the effective dose of this technique is completely safe and significantly less than other techniques. In conclusion, the dentist should consider that in each case, they have to select the technique of choice for their clinical requirements. If they want to see a tooth and they want to see the structure, something like enamel and dentin, they have to use intraoral radiography and use their capability and use their high resolution and sharpness. But if they want to see the third dimension of the jaw bones, it is mandatory to use a advanced technique like cone beam CT. If there is any question, I am at your service. And if there is not any question, my colleague will continue with more detail about radiographic imaging of implant dentistry. I am at your service, Dr. Sadafpour.
All right, thank you so much, Dariush. I do remember we were classmates almost 25 years ago, and it's very great to see you here. Thanks for the wonderful lecture. We got some information regarding cone beam CT and the amount of radiation. Now we are moving on with the next speaker, which is Dr. Bashizadeh. She's Associate Professor of Tehran University of Medical Science, School of Dentistry, since almost 20 years ago. And her topic is the next section of new concepts in radiographic assessments of dental implants. Probably takes a couple of seconds to change the laptops. So if the audience have any question, we do have Dr. Gudarzi here to respond for the questions. Otherwise, we move on with the next. Let's see in the chat room. All right. Thanks a lot. Is she on? All right. Dr. Bashizadeh, it's great to having you here. She's Associate Professor of Department of Radiology in Tehran University. All right, the slides is on. Thank you, Dr. Bashizadeh. Please move on.
Hello, everybody. Thank you for introducing me, Dr. Sadafpour. And a special thanks to my dear colleague, Dr. Farid.
You are welcome. It is our pleasure to have you in our program.
Thank you. As Dr. Gudarzi, my colleague, said, I'm continuing his topic. CBCT is one of the most applicable imaging techniques in implant dentistry because it contributes to accurate measurement 3D assessment of anatomical details, implant size and type selection, aesthetic surgical navigation, it means surgical stent designing and construction, and surgical dynamic navigation. The objectives of this lecture are how to apply CDCT data and images in implant dentistry, and how to apply CDCT data and images in digital implant dentistry. CDCT report by the radiologist contains digital folder containing DICOM files and software to view the files, and printed sheets on radiographic film or photographic paper, or JPEG images on a digital media, for example, CD, website, or PACS systems. A written report to present the radiologist's impression is another form of radiologist report. PACS stands for Picture Archiving and Communication System. Due to radiopedia.org, a modality of imaging technology which helps in imaging transmission from site of image acquisition to multiple physically disparate locations. This technology not only is economical because it's filmless, but also convenient to access multiple modalities, radiographs, CT, MRI, ultrasound, etc. simultaneously at multiple locations within hospitals or across the globe. In CD, you can see many files and folders. The most important ones are the image folder and the viewer. The image folder contains image files in DICOM format and could be imported in any medical software for observing. The viewer is the software which can open the DICOM files and helps you to see the files. When you open the viewer, this page would appear on the monitor and you can see the patient's demographic features. CDCT machine makes hundreds of projections in different angles. Putting this together will shape a three-dimensional cylindrical volume. The object, for example, maxilla and mandible, is at the center of this volume. After that, when you start the viewer, this page will appear on the monitor. The software gives you these default views: coronal, sagittal, and axial. You can scroll on these views and see other sections of each view, but these are not very helpful in implant treatment planning. You need to see the dental arch in another direction and measure the width and length of the alveolar process. So this is the question: which one is the most appropriate view of the jaws for implant treatment planning? Axial, coronal, sagittal, or cross-sectional? For sure, cross-sectional views of the jaws are the most appropriate ones. To obtain the cross-sections, we should determine a customized region in that cylindrical volume to have a panoramic view of maxilla or mandible. A pen tool is available in each software. We select the pen and draw a curve on mandibular or maxillary dental arch axial view. The line is drawn here. The line is completed and the software gives us a panoramic reconstructed view from the line that we had been drawn. After that, the software reconstructed cross-sectional views of the jaws in rows. The position of the cuts is dependent on the position of the line we have drawn. On axial view of the jaws, the software draws the cross-sectional lines at the right angle to our panoramic line. The position of the cross-sectional lines on panoramic view is seen here. Note the numbering at the top. the position of the cross-sectional lines on axial view. Note the numbering at the left. These are Scott views and help us to localize the cross-sections. At the end, we have the cross-sectional cuts with the numbers mentioned on each. Now you can measure the width and length of available bone by achieving the measuring tool in the software. As I have mentioned in the beginning of this session, the radiologist may pass all these steps and gives the report in this format on film, photographic paper, or as a JPEG image on CD packs or websites. Here you can see the Scott and the cross sections. We can find the number of the section on the Scott view, for example, number 40, and then find the relevant cross section. The interval of the lines is adjustable, but how much is sufficient? Practically, in implant surgery, 2 millimeters is the best. More than this may cause missing some important information, and less than that, increase the number of cross-sections unnecessarily and would be troublesome for larger edentulous areas. The radiologist may also give you a written report about the dimensions and other important features. For example, when a right second mandibular molar is considered to be extracted and replaced by a dental implant, we choose two relevant sections and give the width of the crest and the length from crest to mandibular canal. And then an average for each is also given. But which anatomic landmarks are important in implant surgery? In maxilla, maxillary sinus floor, maxillary sinus septa, nasal fossa floor, incisive canal, maxillary tuberosity, posterior superior alveolar artery, and in mandible, mandibular canal, submandibular fossa, incisive canal, mental foramen. Maxillary sinuses are two radiolucent spaces which drilling should not invade their floor. Mucosal thickening can also be observed in CDCT if had been occurred. Maxillary septa, which are important in the case of sinus lifting. The surgeon may be forced to make multiple approaches in sinus floor considering this septa. Nasal fossa is located at the nasal fossa has two radiolucent structures in the midline which determine the upper limit of drilling in maxillary anterior region. In cross-sectional view, they are located medial to maxillary sinus. Incisive canal is located at the palatal side of maxillary central incisors. And the anterior nasal spine, which is the upper limit of drilling in midline area. Because superior to that, there is nasal septa. Maxillary tuberosity is the posterior limit for implant insertion. And posterior superior alveolar artery, which passes through a canal or groove in the lateral wall of sinus, may cause massive bleeding in the case of sinus lifting. Mandibular canal in mandibular posterior regions contain nerves and vessels and should be carefully preserved during surgical procedures. Submandibular fossa is in posterior mandibular region, is a depression in lingual side of the bone and may cause limitations in implant treatment planning. Mandibular incisive canal is the anterior extension of mandibular canal and may cause massive bleeding in the case of damage. Mental foramen in buccal side in mandibular premolar region is seen. Narrow mandibular ridges, which are a dilemma. Insufficient bone in maxillary ridge that requires sinus lifting. Metal artifacts as dark and light regions in vicinity to high atomic number structures like amalgam fillings and crown and bridge restorations. Today, CDCT data have more sophisticated applications in implant dentistry. Navigation is one of these. Navigation, due to Merriam-Webster dictionary, is the act or process of finding the way. A surgical navigation system is in some way the same as a commonly used navigation system in a car. For example, both attempt to localize a determine a position in space in the context of its surroundings. Navigation in implant surgery can be classified into static navigation implant surgery and dynamic navigation implant surgery. Static navigation refers to use of static surgical templates. The procedure of constructing these stents are done with the help of CDCT imaging. The position of drilling holes and at times the construction of the whole stent by 3D printing is not possible without CDCT imaging. In dynamic implant surgery, the bone drilling and the implant placement are completely tracked with a specific software. The software needs the CDCT data. GPS or global positioning system using triangulation with the help of several geostationary satellites to make a digital map of the region and localize signal sender, for example, your mobile phone position in the map. But requirements for dynamic navigation are a stereoscopic camera, a computer platform with screen, the respective navigation software, marker spheres attached to the patient, marker spheres at surgical instruments. This is the schematic view of a navigation surgery in the operating room. And another view in office tracking system, the stereoscopic camera, the computer platform, the respective navigation software, and the markers. How does it work? Impressions are taken, splint is fabricated, a special key is attached to the splint. The splint is located in patient's mouth during surgery, and there is a data sending apparatus on your instruments. The position, size, and angulation of drilling is observed on the monitor. Advantages of dynamic navigation are dynamic navigation associated with flapless surgery and teeth crown supported guides has demonstrated the highest accuracy. Additionally, flapless implant surgery is related to reduced pain, less analgesic consumption, less swelling, short chair time, and reduced risk of hemorrhage while achieving greater patient satisfaction. Thank you for your attention. I'm at your service for any question.
Thank you so much, Dr. Bashizadeh. It was very interesting, especially talking about dynamic navigation is new, actually development in surgery other than surgical guides. Thank you so much for mentioning it.
Thank you.
Thank you for accepting our invitation.
Thank you very much.
All right, we are done with the radiology part. And now we have the first lecturer from Cross Department, Dr. Habibzadeh. She's Associate Professor of Department of Prosthetic, School of Dentistry. She is lecturing regarding virtual treatment planning in implant dentistry. So let's move on with the next lecturer.
Okay. Hello, Dr. Farid. Hello, Dr. Sadehpour. Thank you for having me today. This is really a great honor for me to participate in this short course. And the topic of my presentation is virtual treatment planning in implant dentistry. In this presentation, I'm going to talk about the pathway or the digital workflow that we have for digitally placing our implants. I'm going to talk about the elements of a digital workflow. We'll have a quick review over radiographic and surgical guides. And to put this together, we'll see what the advantages and disadvantages of this method is. And finally, the most important question is that whether this method is accurate enough for us to place our implants digitally. As we all know, the placement of osseointegrated implants is nowadays part of everyday clinical practice, and the surgeon must ensure that the position of the implants facilitates an aesthetically and functionally acceptable prosthetic rehabilitation, and the patient will have an effective oral hygiene right after. Therefore, a crucial role is paid to the diagnostic and treatment planning phase, in which we pay attention to the anatomical and prosthetic constraint in the alveolar bone site. Usually, diagnosis and treatment planning in implant dentistry is based on three important parameters: the clinical exam, the study cast, and the radiographs. However, with conventional methods, simultaneous presurgical evaluation of the surgical and prosthetic results is not possible during diagnosis and treatment planning. Therefore, deviation of the predetermined implant position can occur because there is no mechanism to introduce prosthetic information into the CT or CDCT dataset. Therefore, the value of this technology is limited to diagnostic applications for the evaluation of anatomic structures and post-extraction resorptive patterns. What is the solution here? How can we predict our final results and plan a crown-down approach for placing our implants? The question remains with digital technologies, and the introduction of digital technologies and workflows has reshaped the clinical approach to implant treatment planning and therapy. Due to these advantages in the accurate diagnosis, treatment planning, and implant placement procedures, digital technologies are becoming widely used today. When we hear about digital implant placement, we usually with these techniques and words, we have our three-dimensional CT imaging or CDCT imaging. We have our implant planning softwares. We hear about CAD/CAM or computer-aided design, computer-aided manufacturing technologies. We have computer-guided implant surgery, computer-navigated implant surgery, and recently robotic implant dentistry. What we hear most is these two terms. Two computer-assisted implant surgeries, which are mostly used, are static computer-assisted implant surgery and dynamic navigation. Between these two, the first one has easier intraoperative handling of the surgical templates, requires no additional equipment, and requires less time for the presurgical setup and intraoperative applications. However, dynamic navigation is usually costly and maintains a lot of time for its planning. So the first one usually favors our dentists. With the use of computer-aided design and computer-guided implant placement, we can have several information. For example, parameters such as bone quality, bone volume, and anatomical restrictions can be processed and simulated. The simulation of the virtual positioning of the implant can also lead to the construction of a three-dimensional model for implant positioning, which we call it the surgical guide, or drill guide, or implant positioning guide. This technique results in the precise implantation of the treatment plan and the accurate placement of implants. The software makes possible the direct link between anatomic interpretation, surgical and prosthetic treatment planning, and precise surgical placement of the implants. Bone preparation in relation to the position, angle, and depth of the implant is guided through these procedures, and patient-specific surgical guides are developed to obtain the optimum results of insertion of implants in predetermined prosthetically acceptable position. We hear these words a lot in this presentation: prosthetically driven implants or crown-down approach for placing our implants. Actually, this procedure makes our final results more predictable. Before we start with the workflow, there are several questions that we need to address. So what are these questions? First of all, what are the patient's needs, the expectations? Is a fixed or removable prosthesis required? How many implants should I place for my patient? Are any augmentation procedures necessary for bone or soft tissue? Can I do them before implant placement or during implant placement? Is there a need for a radiographic guide? And which type of surgical guide will be placed during surgery? The possibility of flapless surgery, is it possible or not? And finally, and more importantly, is the construction of an immediate restoration possible or not? Now we go back to the digital workflow, which is the main part in our presentation. Usually we have three elements or three procedures in a digital workflow. First of all is the data collection. Then we have our software for design and manufacturing of the equipments that we need. And finally, there's the implant placement. Here we have a flow chart or a diagram of the full digital workflow. First of all, we have our data collection, which is mainly done through CDCT and CT imaging, and also optical surface scanning of our cast model. Then we have our software to design. We have our virtual implant and prosthetic planning. And in the next step, we can have our guides and prosthetic components manufactured with the use of computer. And finally, there's the surgery day in which we place our implants and hopefully deliver our prostheses. Okay, the first step in this workflow, as we stated, is data collection. As my colleague already talked about, this part, data collection is usually performed through an imaging technique. And the first step in the digital workflow is data collection through digital imaging and also optical surface scanning. We usually have two methods for our imaging, CT and CDCT. CDCT has recently gained increased acceptance because it has lower radiation dosage and relatively easy to be used in a dental environment. The quality and the diagnostic value of the images always remains the main factor in choosing between these two techniques. And one thing to keep in mind is that the knowledge and experience of the radiologist is very much more important than the imaging equipment, method, or protocol used. So the decision to use a CT or CDCT always remains with the clinician. But both of these techniques provide sufficient and useful information, and the data which are derived from these imaging techniques are usually stored in a universal format for digital imaging and communication in medicine, or we can call it the DICOM or DICOM format. So from the CD and CDCT, we'll have a DICOM file restored in our software. CDCT has several advantages. It provides us with information regarding the pathology of the area, vital anatomic structures, and also the quality and quantity of the bill. There is an error usually while we're measuring anatomical structures in the CDCT for around 1 millimeter. Therefore, if we want to avoid these errors and have a predictable final result for our implant placement, then usually radiologists recommend that a 2 millimeter safety zone should be considered when measuring how far the proposed implant is going from vital structures. When we take our imaging technique, we usually read a guide, which we call it a radiographic guide or a scan prosthesis. And this guide will delineate the ideal position and orientation of the future teeth. It also allows prosthetic information to be introduced to the CT or CDCT dataset to aid in the placement of a prosthetically driven implant. Unfortunately, CT or CDCT does not sufficiently display the tooth surface for the prosthetic setup. Therefore, we usually need another scan and another file, which is derived from a virtual dental model through an intraoral scanner or an extraoral scanner. That could be a scan of the impression of the patient's stone casts. So from these data, we'll have another file called the STL or Standard Tessellation Language file. So the STL file is usually derived from an intraoral or extraoral scanner. Okay, we'll store this second file in our software, and now we have two different files, the DICOM file and the STL file. Now, what we need to do is to register or merge these two files in our software to have our final data collected. The process of aligning multiple imaging data sets with each other is defined as registration or merging. And it should be done as accurately as possible since implant position will be planned based on this merged data. So any inaccuracies will result in the final problems and complications in our implant placement. So in order to do the registration or merging, we have different procedures that can be used to accomplish an accurate registration. We can use the tooth surface, or we can have custom or standardized reference markers, which are called the fiducial markers. Okay, as we said, different protocols are provided for merging. So the first one is the single scan protocol. As the name implies, it only has one scan of the patient, and that's the one with the patient wearing the scan prosthesis. So with the patient wearing the scan prosthesis, or radiographic guide will take a CDCT scan. And then by incorporating standardized markers into this, we can register the stored data in our software, and virtual implant planning can be performed. However, we need a special positioning device for this method. And usually the surgical guide is fabricated in a laboratory or by a dental technician and not by the CAD/CAM procedure. The second procedure or second protocol that we have to merge our data is the double scan protocol. So in this procedure, we have customized fiducial markers, usually made of gutta-percuspheres. And as the name implies, we have two protocols. The first one is the CDCT scan with the patient wearing the scan prosthesis, and the second scan will be from the prosthesis alone. So then we have these data gathered, and as the fiducial markers are visible in both set of scans, then we can merge these two scans together. The disadvantage of this method, the double procedure or the double protocol, is the extra time and cost required for fabricating the scan prosthesis. Moreover, if the sitting of the scan prosthesis is not okay and is not correct, then the whole planning of the implant procedure will be based on an invalid foundation, and therefore it will be incorrect. So the sitting of the scan prosthesis during taking the CDCT or CT is very important with this method. Okay, here we have an example of a double scan procedure. Here we have the digital dental cast scan and also the CDCT scan of the patient, and these two are merged with fiducial markers. Here we have gutta-percuspheres, and we merge these two files and have our final results. As we said, we can have gutta-percuspheres, which are placed in existing temporary bridges, patients' partial dentures, or even diagnostic wax-up. Sometimes we can have our scan prosthesis in a radio-opaque way. And in this form, we can have the ideal position and inclination of the missing teeth, as well as the boundaries of the soft tissue. So we use barium sulfate, which is usually 50% for the base and 30% for the teeth. And in this way, you may have a scan that is like this. You can see that the ideal position and inclination of the missing teeth is provided in your scan and can guide you to placing your implant digitally. Okay, we talked about the one scan protocol and two scan protocol, and here is another protocol for merging these data, and it's called the image fusion procedure. So this one is based on dental surface registration, and it has excluded the need for scan prosthesis in planning implant placement. In this technique, a virtual dental model can be acquired by scanning the stone model, or an intraoral scanner can be used to scan the area in the patient's mouth. And then by identifying some corresponding points on the dental surfaces of the digital dental cast and the 3D volume of the CT scan, then we can merge these two data together and have our final data. So this procedure excludes the need for scan prosthesis. So it reduces a lot of time and cost on implant planning. However, some errors might happen in this form, and this procedure cannot be applied in certain clinical situations. For example, when the patient is fully edentless or has a few remaining teeth. Here is an example of merging or matching the digital dental cast with CBCT scan. This is the third protocol, which is called image fusion. And as you see, there is no need for a radiographic guide or scan prosthesis. This technique also might have some inaccuracies, which are mostly related to the use of scanners. You know, when you are aligning and stitching the images with the intraoral scanner or extraoral scanner, then you might face some errors, and especially this cannot be used in an edentless patient. There are some other obstacles, such as the limited intraoral space for the scanner head or the reflection caused by metallic restorations or cellular flow. Of course, the reflection can be somehow corrected by using a titanium dioxide powder. On the other hand, we can use an extraoral scanner and scan the stone cast of the patient. So in this protocol, we usually take an impression of the patient's mouth, then pour the cast and scan the cast with the use of an extraoral scanner. All right, going back to the elements of a digital workflow, the second step is computer-aided design and manufacturing. Here we're dealing with a software. The software creates an interactive digital environment so that the dentist can fully and independently manage the patient's image data. As we already talked, we have two sets of data. One is derived from the CDCT, we call it the DICOM file, and the other one from the scan, and we call it the STL file. These two are merged, and then implant-supported restoration can design in the software, and we can do it so that a prosthetically driven implant is finally placed. The prosthetic setup and the software usually combines the ideal position of the implant-supported prosthesis, and it considers the abutment design with its emergence profile, morphology of the tooth, occlusal and proximal contacts, and so many other considerations. One of the most important things that we have to consider are the anatomical and prosthetic principles. And in the same software that we place our implant, we can design the prosthesis which is used in implant placement, the prosthesis that we call it a surgical or drill guide. Many CAD programs are available for designing our prostheses. In the software, we will have standard teeth shape, additional shaping tools, and even virtual articulator to facilitate accurate and efficient tooth setup. On the other hand, we can have the conventional wax up and then scan the wax up, and hopefully the final outcome does not change whether you are using a conventional wax up or you are using things from the software. But of course, if you are going with the wax up technique, then it requires additional time and expense to provide the wax up. Here in the software, we have an electronic library, and we can choose whatever system, whatever diameter and length from the implant we need from that library. Then we have several considerations for our implant placement. For example, the proximity between implants or between implants and nerves and other anatomical constructions must be taken into account. The possibility of creating virtual teeth, designing individualized abutments, simulating grafts, and even bone density can be accomplished in the pre-surgical treatment planning phase. Okay, for example, for anatomical and surgical considerations, we have the minimum amount of 1.5 millimeter of bone that must be present to the buccal bone to ensure optimal static and pre-implant soft tissue stability. If you're placing implants next to each other, then a 3 millimeter mesiodistal distance should be kept between implants. And regarding the depth of the implant, you should be careful that if you're using a bone level implant, it should be placed 3 to 4 millimeter apical to the planned prosthetic margin. And this amount is usually 1 to 2 millimeter for tissue level design implants. Here you see that if there are concavities in the maxillary or mandibular arches, then during implant placement, we can see them and avoid them. Of course, if there are dehiscences and fenestrations, the software will alert us and then we can escape placing our implants in such positions. Another important factor is regarding the possibility of simultaneous augmentation with immediate implant placement or the need for a two-stage approach. So with this technique, you can simulate and see whether you need to perform your graft prior to implant placement or whether you can do it simultaneously. Then the location and size of mental and nasopalatal foramen are evaluated. And we have to be careful not to place our implants in these areas and keep the amount needed between our implant and these nerves. It will be the same for the inferior alveolar nerve, and virtual implant placement is indicated in an acceptable position regarding to the inferior alveolar nerve. Another important feature that this software provides us is to evaluate the bone quality, and this is done through Hounsfield units, and it provides us with information regarding the bone density, which is very important for your initial implant stability. So after the implant position is planned according to the appropriate considerations that we already talked about, the clinician can start designing the surgical template. And the surgical or drill template is usually made with respect to the type of support, sleeve to bone height, drilling distance, and also the number of teeth used to support it in a tooth-supported template. Finally, with the use of CAM technology, we can bring this design and whatever we have virtually into reality. I'm going to go over surgical guides very briefly because I know my other colleagues are going to discuss it in detail. So we have basic and advanced guidance. We can have two protocols for performing our implant placement. We can have a combination of analog or digital technique, or we can have a fully digital workflow. Of course, the fully digital workflow is superior when you have multiple implants next to each other. And in this technique, everything is designed virtually. And finally, with the aid of computer-aided manufacturing, use of resin blanks and other materials, we can produce our guides. So it can be a milling process, or we can have it with one of the additive technique, for example, rapid prototyping. Fortunately, both of these procedures are clinically acceptable. Here we have a flowchart of how we are turning our surgical STL file into a surgical guide, which is usually used through CAD/CAM or a 3D printer. The material that we use for our surgical template is usually resin because it is accessible and it facilitates the clinic. In the clinic, we can use it very easily and it is easily fabricated and the cost is quite justifiable. However, these surgical guides, which are made from resin, are a little bit thick and bulky, so they may limit the accessibility to the surgical area or the surgical view. And in these cases, we can have other materials such as metal or zirconia, but of course, they're going to be very costly and their manufacturing requires a lot of time. As already stated, we can have our surgical templates, usually based on their support. We can have bone, mucosa, or tooth-supported surgical templates. Whenever possible, clinicians prefer a tooth-supported template because it has superior accuracy. But we can have bone-supported templates, which are slightly invasive. And in order to place them, we need to have a mucoperiosteal flap. It should be reflected. Therefore, they might have some post-operative discomfort for the patient and even possible bone loss due to decreased blood supply. Here we have an example of a bone-supported surgical guide. You can see that a mucoperiosteal flap is required to place these surgical guides. On the other hand, we can have mucosa-supported templates, which are less invasive, and therefore they can reduce the post-operative pain and discomfort for the patient, and the surgical and healing time are reduced. But this one, of course, depends on the mucosal thickness and resiliency of the mucosa, and it might not be as accurate as bone-supported implants. The tooth-supported guides are the most commonly used, says that they allow for a flapless or minimally invasive surgery with minimal buccal flap elevation. And here you see an example, and usually it is required that two teeth on other side of the surgical guides are remained. The design of the drill guide can also vary depending on its function. It can only guide the pilot drill, or it can guide every drill of the implant-specific sequence. And I'm sure my colleagues are going to talk about this in detail, so I'm going to skip this. And it is recommended that we use the guided protocol for the multiple implant placement because it's going to be more accurate than the first one, which only has the pilot drill guided. Okay, after we design and manufacture our surgical template, then it's going to be the implant placement session. Here you see an example of placing our implants with several surgical guides. All right, after having this review over the workflow of digital implant placement, we'll check the disadvantages and advantages of this method. So the most important advantage of this method is the ability to predict the final results. And the other thing is that all specialists are involved from the beginning. So the surgeon, the prosthodontic, and as we already stated, the prosthetically driven implant placement will be fulfilled. It also minimizes the possibility of entry to important anatomical structures and allows the possibility of using the full width and height of the available bone, because you can check this in the software and see whether you can place your implant in the most suitable area. If you use this technique, we will avoid more complex techniques such as sinus augmentation and bone grafts, and the operating time is reduced significantly, especially in complex cases. Minimal post-operative discomfort is estimated because we usually do not have, the surgical area will be very controlled, and you can have flapless surgery, so you do not need to raise a flap, and therefore it's going to be very much comfortable for the patient. And another important feature is the use of temporary or definitive prosthetic restoration, which are constructed prior to implant placement and given to the patient on the day of the surgery, which is very advantageous for some of our patients, especially the ones who are completely edentulous. Here, we see some of the cases together. For example, with the use of this technique, we can avoid problems such as this case. You see, these problems usually demand complicated and expensive surgical and prosthetic solutions, and sometimes they are unsolved. But with the use of digital implant placement, we can predict the final result. There is a lesser chance of accidental nerve injury with this technique, as you see in this picture. Root injuries are reduced, and the problems with inadequate space for the prosthesis are usually solved because we have a prosthetically driven implant placed. For the last part of my presentation, we will answer this question, that whether this technique is accurate enough for us to place our implants with. So accuracy of this technique is usually defined as deviation between the planned and fixed implant. And studies have shown that this technique shows some degree of imprecision, resulting in deviations between actual and virtual implant position. So this can be attributed to every step of the flow chart, for example, during data collection or transferring or processing, or during implant treatment planning, the CAM procedure, or the surgical placement of the implant. We have several studies in literature that have discussed the accuracy of this method, and interestingly, even in difficult cases such as zygomatic implants and implants in the trigoid process or significant alveolar atrophy, the precision of the method remains within 1 millimeter, and the differences in angle placement is usually smaller than 6. However, most of these clinical reports have involved only a small number of patients and implants. So there's a lot to go. We need to discuss these. We need to perform randomized clinical trials to check the accuracy of the method so far. In conclusion, the accuracy of this technique is high, and it usually we usually have most of our problems with taper drill guides, and deviation is to be larger at the apex compared to the top. And it is usually proportional with the increased length of the implant. For the clinician, what we can suggest is that the perfect positioning of the surgical guide is very important. It's actually the most essential requirement. And we should always keep in mind that safety distance of 2 to 2.5 millimeter, which should be kept between the implant and important anatomical structures. So in conclusion, the advent of digital workflows for implant treatment has increased accuracy, and luckily, we can have our implants placed digitally nowadays, and due to the benefits that this technique provides us, it has come to more predictable and successful implant outcomes for our patients. Thank you very much for having me here.
Thank you so much, Dr. Habibzadeh, for accepting our invitation. It was very comprehensive and very beneficial. And we have a question. Thanks for excellent presentation. What about irrigation in surgical guides? Is it possible to have enough irrigation to prevent heat?
Sorry, could you come again? What was the question again?
This is in the chat box.
Okay, let me see if I can see the chat box. Okay.
Yeah, thanks for excellent presentation. Also, we thank you.
Okay, so is the possibility to take digital impression with a scan body at the session of the surgery?
No, the last question. What about irrigation in the surgical guides? Is it possible to have enough irrigation to prevent it? Almost the last one. One behind.
Okay, okay, I can see it now.
Yeah.
Which one is it?
What about irrigation in surgical guides? I think.
What's that? About irrigation in the surgical guides? Is it possible to have enough irrigation? I believe our surgeons could explain that more properly, but I think, yeah, we can have that. But I'm going to leave this question to be answered by our next speaker.
Yes, Dr. Abbasi, I'm sure
I think he can explain it
more
well.
eligible to answering this question rather than a prosthodontist. However, Dr. Habibzadeh, it was wonderful. Thank you so much.
Thank you very much. And I really would like to thank you for your efforts. I know you've been through this for quite a month or two, I don't know, but the planning and everything was perfect. Thank you very much.
Thank you so much. Okay, and our next Abbasi, oral and maxillofacial surgeon, associate professor of Department of Oral and Maxillofacial Surgery, School of Dentistry, Tehran University of Medical Sciences. He's also a member of Department of Oral and Maxillofacial Surgery, Sina Hospital of Tehran University of Medical Sciences. Dr. Abbasi is also a fellowship, has also fellowship of facial cosmetic and constructive surgery. I should say that, Dr. Abbasi, we are so grateful that you accepted our invitation for coming and talking about guided surgery in implantology, pilot guided surgery. As you know, we may have different kinds of guided surgery, and we can't wait more to know what Dr. Abbasi is going to talk about.
دکتر خیلی ممنون، واقعا زحمت کشیدید. آره خیلی عالی بود، خیلی خوب. آره دو تا تعریف داشته، دست درد نکنه. فعلا که چت بان. ولی من مطمئنم جای دیگه ما بیشتر از این داریم. فعلا 22 الان زده 22 تا، ولی من مطمئنم بیشتره. بیا خانم دکتر، بیا بشین عکس بگیریم.
Okay, Dr. Abbasi, we are the screen is yours. Please go on.
Thank you very much. Hello, everybody. I'm honored to distinguished professors and my colleague and dear students. Let's show.
Take your time, Dr. Abbasi. You are ahead of the time, and don't worry, you have enough time.
We have a little problem for presentation now. I think that we must wait for a minute to continue.
It's okay. It's okay. As I told you, you are ahead of time. You have about 2 or 3 minutes. It's okay.
Hi everyone, my name is Soha. Did you know that Tehran University of Medical Sciences is the oldest and most well-known medical center in Iran, nationally and internationally?
Tehran University of Medical Sciences also has the largest school of dentistry in Iran. Take a look inside.
School of Dentistry is organizing its classes following health protocols. You will join large lecture classes like this.
Restorative Department of Dental School of TUMS and Tissue Restorative Dentistry. Restorative dentistry is the main part of dentistry. Actually, it consists of two parts. Theoretical part and
Or small practical classes like this.
I hope you picked the right major. Have you picked yours? This will come in a School of Dentistry. Go to TUMS website and pick yours.
During studying, we have access to a wonderful hospital, giving us opportunity to have more experience.
And of course, sometimes you need to relax. Dentador konflikülliyeti esnaf TUMS.
Hoş geldiniz. Bekliyoruz sizi. We are waiting for you in a School of Dentistry TUMS.
We are all familiar with conventional prosthodontics, how to prepare teeth, how to make impressions, the laboratory procedures and delivery steps. But like other aspects of our lives, prosthodontics is getting more and more digitalized. And being familiar with digital prosthodontics, especially CAD/CAM technology, is mandatory for an up-to-date dentist. That's why we have planned a short course in digital prosthodontics. Join our outstanding program at Tehran University of Medical Sciences School of Dentistry.
Choosing some majors, you will have to pass long academic years and spend much money. Wait, TUMS has a great offer for you. Do you know by studying dentistry and pharmacy, you will save time and money, study less difficult and complicated courses, and above all, you will have a great job opportunity? This is the last time our DDS and PharmD programs are on a special offer with 50% reduction. DDS from $7,500 to $3,500. DDS from $7,500 to $3,750. B-Pharm, M-Pharm, and PharmD from $6,500 to $3,000. It's time to take action. Don't hesitate to use the new chance.
Please, our colleagues, please stay with us. It is going to be fixed. We have a small problem. Okay, dear colleagues, now the problem is fixed and we are going to have our next speaker, Dr. Amir Jalal Abbasi. As I told you, he's oral and maxillofacial surgeon, associate professor in Tehran University of Medical Sciences and in Sina Hospital. He's also a fellowship of facial, cosmetic and reconstructive surgery. Dr. Abbasi, we are so grateful because of you being with us and accepting our invitation. Please, the screen is yours. If everything is okay, please go on.
Thank you very much.
We can't hear you.
Okay, thank you very much, Dr. Farid.
Dr. Abbasi, we can't hear you.
Perhaps you are mute.
صدا
Is he
ندارم.
mute? Okay, as I see here, the audiences can hear you. Please go on, Dr. Abbasi. Audiences can hear you.
Okay. It's okay now? It's okay.
So our audiences, can you hear Dr. Abbasi? Would you please write to us again? Can you hear Dr. Abbasi?
زاویه چیه؟ اونا محرم Hello everybody. I'm here now after effort of the team. I am connected now. I speak about part 2 of my presentation and introduce 4 cases. Working. Again. Okay. As you see here, it's conventional guide, depth control surgical guide. We use conventionally this guide for guided surgery, implant static navigation. In this case, we use this guide for installation for implant. It's universal kit of materialize, and we use this kit for installing the implants. As you see, the spoon of kit we use in the sleeve, and after drilling, we insert implant without using the guide. Okay. And you see here the implants. Good angulation and the best position we can insert the implants. In case 2 is a woman with a severe atrophy case and candidate for reconstruction by iliac graft. As you see here, deficiency of alveolar bone and sinus. In 3D image after iliac graft, you see mucosa and the teeth, and choice the best position of the teeth arch. And designing the best situation of the implants. And see here the implants and overlay prostheses, and we can evaluate the best position for prostheses and implants. The data sheet reveal us the position of implant and guide us for drilling and positioning the implant in day of the surgery. Now, this is the clinical view, and you see the iliac graft. We remove the pins and the screws. We use instrument navigation kits. One of the best kit in navigational surgery is instrument kit, and we use the conventional static guide and fix it by pin, and using the spoons for drilling and drilling the position of the installing the implants. We fill the defects of You see there with the allograft and final results. You can see this final. Special thanks from special thanks to Dr. Nyakam for prosthetic treatment. Now speaking about guided pilot drilling. Pilot drill templates intermediate connector between traditional surgical methods and fully guided surgery. The benefit of this method, computer-assisted treatment planning, manage and control direction and depth of implant insertion based on the patient's anatomy examined after lap elevation, managing either soft or hard tissues, and can do GBR. Major advantages is simple and inexpensive. It doesn't need brand-specific implant surgery setting. The disadvantages: impossibility of immediate loading, impossibility use of prefabricated temporary prostheses. What we can do? Only one primary drilling is done under the guide of the splint, and the rest of the drills are used conventionally without guide. The changes in implant position will certainly expected to be more than in fully guided method. This is a case drill with the poor prognosis, restoration, and teeth. You can see here segmented the teeth and the jaw, and you can see the alveolar inferior alveolar. Here teeth are alveolar bone. You see the narrow teeth in alveolar bone. We can't install or insertion fixture in this situation. The proper sequence, as you see here. Now you can see the number of 46, 44, 42. In this position, we have enough bone. And another 34, 35, 36 in the left side. We use cutting guide for leveling the bone after extracting the teeth. We use simple kit for lower jaw in this patient. The simple kit is like pilot drilling. It's two line. It has two long drilling, one pilot and another 3.6 diameter drill. We use. It's now here you see the guided surgery spleen in the position. After installing the implants, we see the defects was filled by a mixture of autogenous and allograft bones, mixture by blood, and using the membrane for completing the GBR. And after surgery, we extracted the upper jaw teeth and reconstructed by alveolar by grafted bones. After 4 months later, we start surgery of upper jaw. It's ready for installing the implant. The splines was prepared for full kit of dentium navigational surgery kit, and you see the final results. And the last case, now you see the poor prognosis of peace and restoration. You see the CDCT views of patients. We decided that sinus like two-stage sinus lift on the right side and extracting the teeth. After 6 months, we decided to installing the implants, and this is design of process and back sub and in relation to proper position of the implants. And the lower jaw, you can see the design and designing the screen over this design. And this is a data sheet in the surgery we can use for installing the implants in precise position. Now in the surgery, we use the splint, bone support, pilot drill, splint. And after drilling, you see the jaw, lower jaw, and now this, after surgery, the final results. In part 2, you can see designing the specific abutments, designed for customized abutments, and now abutments, and final result of the surgery. Thank you very much.
Thank you so much, Dr. Abbasi.
Thank you very much.
We had 2 questions. One was from the former one that was about the drilling during and irrigation during drilling. Would you please explain for our audiences?
In the guided surgery, in any systems, we haven't any irrigation, and we do drilling with very low speed, like the system of DialNavi. And but in other system, we like that use irrigation for lowering the temperature, and we can use from internal system angle for drilling the implant, and any system has internal system for irrigation, but we can design any surgical spleens with hole and irrigation system in the spleens that we can irrigate in this hole for reaching the serum for the irrigation in drilling sites.
Okay, so is there any other question? And I want to know if the past question is answered completely or not. I can't see the former ones. I don't know how can I see the former ones.
It's not question about.
No, yeah, it seems so. It's not more question. Okay, can Dr. Abbasi repeat again about irrigation? Would you please say about the irrigation? I didn't understand.
Okay, in the have you our voice or I type for you?
You can talk again. There's no need for
Oh,
typing.
okay.
Yeah.
For irrigating, okay. For irrigating in navigation system in implantology, we use any type of screens by designing the holes in the screens for reaching the water or serum to site of the drilling site, or in any system they hasn't any irrigation. They propose that you drill in low speed, very low speed, and it's not required to irrigation. But the best one is using the internal system on for drilling the whole of the implants insertion. That the system it has a pipe in internal system and using the drill that has a hole in the tip of the drill that reach the serum or water in the drilling site.
Okay, is there any
Okay.
other question? Thanks.
You're welcome.
And thank you so much, Dr. Abbasi. Thank you because you tolerated our glitches and our problems with the internet. And dear audiences, our colleagues, thank you so much for being and staying with us. For today, our program is closed, and see you tomorrow at 9 o'clock morning. Goodbye, everybody.
Thank you very much.